Thank you, Dr. Possible. I think it's a very interesting paper. It's mainly comparing between a tricyclic antidepressant. I think the drug you have taken is a mitriptyline, and the SSRI, the selective serotonin inhibitor, escitalopram. Of course, as far as we know, the efficacy as an antidepressant is more or less equal in both these groups. But to be frankly speaking, the side effect profile is very much important, because the side effect profile is very much less in case of SSRIs compared to the tricyclic antidepressants. And the other important thing, that also are aware, suicide is considered to be one of the important psychiatric emergency, and we need to act very sharp and very actively. And it's a very important topic. And I think that any comments from the audience or any questions?
After this conclusion, at least the patient is having depression, at least 6 weeks, madam. That is sufficient. That means according to that, we can categorize whether patient is comes under mild, moderate, or severe depression. There is no need of taking all symptoms, which are using commonly here. That's why I have used this standard scales, which are especially used in enhanced and other countries like US. Thank you. There is need of ethical assessment. I have taken ethical permission from here, WIMS, and I have taken.
Yes, answer whether 6 weeks is enough or not. Actually, it takes about 3 weeks' time for development of to see the efficacy of the drug for antidepressant. So 6 weeks is enough to judge.
3 to 4 weeks is a lag period.
Thank you. Congratulations to the Department of Pharmacology and Madam for this paper.
Now we.
My presentation is on functional outcome of laminectomy and discectomy, lumbar intervertebral disc products. Introduction. Low-back is a common complaint with which most of the patients come to our orthopedic OPD. According to the National Center for Health Statistics, back and spine impairment is the most frequent cause of limitation of the activity in people younger than 45 years and affecting the economy and productivity of the nation. Lumbar disc prolapse is an important cause of low back pain, and laminectomy and discectomy is the gold standard for surgical intervention in patients with prolapsed intervertebral disc in whom conservative treatment has failed. So we have taken this as our study. Diagnosing the intervertebral disc prolapse, clinical diagnosis and radiological diagnosis. In clinical diagnosis, we diagnose the nerve root irritation signs by SLR with the straight leg rising test, bell leg rising test, and Lessig test, and by motor test by detecting the power of extensor hallucis longus and extensor distal longus, which are supplied by the alpha nerve root. And we also test the sensory test in the lower limb dermatomes to find out where the lesion is. And we also test the reflexes, the knee jack, which the nerve root for this is L3 and L4, and ankle jack, the nerve root for this is S1. After finding out the lesion clinically, we come to diagnose radiologically and confirm the diagnosis by X-ray of lumbosacral spine, AP, the anterior-posterior view and the lateral views, and confirm it by MRI, magnetic resonance test of lumbosacral spine. The patients and methodology. We have taken 40 patients with lumbar disc prolapse treated surgically in our orthopedic department during the period of November 2012 and June 2014. The inclusion criteria are patients aged over 18 years and above, lumbar disc prolapse diagnosed by MRI, and fitness for the surgery and consent for the surgery from the patient and their assistants. Exclusion criteria: discectomy with interbody fusion and patients who were lost to the follow-up. Our surgical technique. In the surgery, first we give the general anesthesia to the patient. The position is modified knee positioning, and after draping the patient, we identify the level at which we operate by C-arm, and after identifying the level, incise the skin and dissect the paraspinal muscles, and we will find out the spinous process and remove the spinous process and lamina, and we will find out the dura. After retracting the dura, we will find out the disc material which is protruded out, and we will take it with the rongers. This is the disc material we have taken out, and after removing the disc material, we will close it by layers and under the drain. These are the post-operative care. In the post-operative care, we allow the patient to turn on the back at will immediately after the operation, and the patient is allowed to stand with assistance after the surgery, and the increased walking on daily basis is recommended. As the patient distance increases, gentle isotonic leg exercises and stretching are started. And we follow all these instructions. We give all the instructions to the patient when to start sitting for the longer periods and when to do his heavy works, and all these instructions are given to the patient. And we follow the patients for 6 months, and during the follow-up, we come to their functional outcome is evaluated based on the ODA score. The ODA score is the Oswestry Disability Index. In this index, there are 10 sections. The first one is the patient the pain intensity, and then personal care like washing and dressing, etc., and lifting weights, walking, sitting, standing, sleeping, sex life, social life, and traveling. Depending on each section, there are 5 questions. We'll give the scoring for each section. The total personal score is 5, and if the first statement is marked, the score is 0, and if the last statement is marked, we give the score 5. On this scoring, we'll do the ODI score and give the percentage. 0 to 20% is the minimum. 0 to 20% is the minimum disability, and if the score is 21 to 40%, it is moderate disability, and it is 41 to 60, it is severe disability, and 80% it is crippled, and 80 to 100% the patient is bedridden. The results and observations. The age distribution and sex distribution, so shown in these figures. The age distribution. Most of the persons are between the age of 41 and 60. It is approximately 62.5% of the population we have taken. And sex distribution, males it is more prominent in males, which is about 65%. And occupation, heavy workers are more prone to this intervertebral disc products. It is about 67.5%. And outcome based on ODI, we have got the minimum disability score in about 72.5% of the patients, which is a good result as compared to the other studies. The complications we get are the superficial infections, which are recovered without treatment, and disc infection, which is also recovered. And dural tear, we unfortunately got the dural tear, but it was not completely recovered. Outcome in correlation with the occupation. With heavy workers, the disability, minimum disability is less, and with moderate and severe disability, the outcome is more poor in the case of heavy workers, which is proven by the Graver and the Lopez in their studies. The summary is 62.5% patients are aged about 41% and 40 to 60 years, and 65% are males. All these are proven by the Horrell and Calce and Hulse in their studies, and we also found out that the results are, the functional outcome is poor in heavy workers. Thank you, sir.
Everyone is open for discussion.
We treat, he cures. Next please. Thanks the organizer for giving me opportunity to present the case. Mike. This is a rare case of pseudomyxoma peritoniae. Pseudomyxoma peritoniae is a rare occurring in about 1 person per million per year. First described by her is a rare complication of mucinous tumor of the appendiceal or ovarian origin that results in peritoneal and omental implants. Other rare sites being colon, stomach, gallbladder, pancreas, ureter, urinary bladder, any place where a mucin secreting cell is present. The exact pathogenesis is very controversial. Clinical morbidity and mortality results from copious amount of extracellular and peritoneal mucin causing distortion and loss of function of the visceral organs. Unrelieved compression can lead to adhesion and morbidity, including pressure symptom of renal cavity, obstruction, and death. They described a classification for this They are peritoneal adenomyogenesis, peritoneal mucinous carcinomatosis, and an intermediate form. Recent research indicates clinical symptoms to be caused by overwhelming production of mucin 2 from mucin 2 secreting cells. So the recent treatment is directed against these cells. Coming to the case which we treated here in MIMS is a 42-year multiparous lady who came with complaint of dysmenorrhea, dysuria during menses since 1 year, sudden distension of abdomen since 15 days, breathlessness and loss of appetite since 15 days, loin pain since 15 days. She was apparently alright 1 year back. To start with, she had dysmenorrhea, dysuria since 1 year and gradually loss of weight which was aggravated since 15 days, sudden distension of abdomen, loss of appetite, and suddenly there is onset of left-sided loin pain. She is a para 1, live 1 and abortion 1. Her menstrual cycle was regular and 1 by 30 days with scanty flow. On examination, she had an anxious look and there is shortness of breath. Per abdomen examination revealed a 34 week size cystic consistency, smooth surface, ill-defined border, non-tender. Lower pole was not felt. It was dull on percussion, but there was no shifting dullness. Perspectivum cervix was drawn up. Her vaginal uterus was retroverted, non-tender. Left-hand anterior fornix was full. Right fornix was free, and there is no other systematic abnormality. She was a hypertensive on treatment and controlled blood pressure. Imaging study revealed ultrasound finding of a heterogeneous linear strands inside the peritoneal cavity with internal echoes, and ultrasound suggests a pseudomyxoma peritonei. Other biochemical parameters were within normal limit, but for CA125 was 344 international units per ml. CSCT was advised subsequently, which detected a 31 into 26 into 17 centimeter mass occupying the whole of abdomen that was extending from epigastrium to pelvis, with the uterus was elongated with the stalk and the whole of the peritoneal cavity with fluid was filled with. There is no encroachment of the liver margin, perihepatic connection, no encroachment onto the splenic margin, which was a feature of carcinomatosis scalloping of these organs. That was not there. So they gave a correct diagnosis of a preoperative pseudomyxoma peritonei. The ultrasound showed a elongated ovary, the uterus was elongated. So a preoperative diagnosis was possible to be pseudomyxoma peritonei. We opened it, it was failure to decompress it, and so we seen that there is a fused left ovarian mass with the strands of tissue, elongated pedicle. So left salpingo-oophorectomy was done. Subsequently, total abdominal hysterectomy with right salpingo-oophorectomy done. Peritoneum was showing involvement, and 10 liters of synthetic mucin was drained. Then PAH, RSO was done. Appendectomy was done. It was a mucocele of the appendix. Post-operative patient recovered well without any significant positive finding. Histopathology found it to be appendix was showing mucin secreting cells and the lining epithelium to be intact. This is the cut section through the mucin was showing lining epithelium of the ovarian cells with mucin inside the peritoneum within the lumen. And this is the high power field which shows there is stratification of the mucus lining, but the basement membrane is intact. So the report was suggestive of a mucinous adenoma of ovary and mucocele of appendix with pseudomyxoma peritonei. So this is a false mucinous tumor of the peritoneum. There is multifocal peritoneal serosal omental implants giving rise to the jelly-belly appearance. The mucinous carcinomatosis and mucinous there is DNP is the benign form. This is the malignant with metastatic involving all the viscera, but our case doesn't show any visceral involvement. We have also done a peritoneectomy and a total comentectomy. 10% of the patients die of PMP within 5.5 years of their initial presentation, while others experience a recurrence of residual disease. Virtually, this is the most important slide, inviting all controversies and conclusions. Virtually every known solid tumor has the primary malignancy near the epicenter of the cancerous mass. with few exceptions, at the time of diagnosis, the primary tumor is the most massive tumor deposit and causes the symptoms that bring the patient to physician. In contrast, with pseudomyxoma peritonei, the primary tumor is usually inconspicuous and rarely causes symptoms because of its size. But unfortunately, our tumor was going along this massive presentation on the left mass, so we take it as if it is an ovarian origin. Then HIPEC is the recent treatment, heated intraperitoneal intraoperative chemotherapy with mitomycin or 5-fluorouracil or cyclosporine cisplatin. Then the final diagnosis comes with histochemistry and genomic studies, which will give a final clue as to the tissue of origin. These are my references, and I acknowledge the patient, Professor P. Srinivasmurthy, our department professor, Professor Sam Prasad. Thank you all.
Thank you. Thank you, madam. Thank you, madam, for your music presentation. Now I request the audience to pose some questions.
There was no point to go for a preoperative FLSE because you have given a lucid diagnosis of that. I want to give another example. We had here come across another case of pseudomyxoma peritonei, which was a for-operative and pseudomyxoma, but it was a per-operative diagnosis. But you have given CT pictures and the ultrasound pictures suggestive of pseudomyxoma. That was very correct also. I think in that diagnosis point, FLSE doesn't have any value. But we tried FLSE before surgery intraoperatively to decompress it, but it was a failure because FLSE में that mucin was impossible to draw.
Actually, it's easy.
This was not possible actually. FLSE